No, I didn't mean to do that. Let me do this. Alrighty. Woohoo! Hello, everybody. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. That means, if you've never heard the term interstitial cystitis, what that means is that you have pelvic pain. You might have frequency, urgency, pressure pain, but there can be a number of symptoms associated with having chronic pelvic pain. It could be tight muscles. It could be pelvic congestion syndrome. There are lots and lots of questions here that we want to try to give you context to help you find better care, ultimately. I normally do these meetings on Sundays. Hey, Mary. Mary, nice to see you. And I simulcast live. We're simulcasting on two separate computers. So if I'm looking over here, I'm looking at YouTube, and they are on AT&T. And if I'm looking at here, I'm looking at Facebook and Instagram, and this is Comcast. So we will hope things go well, because there are moments when internet doesn't go well. Hi, Shirley. Nice to see you. So it's been a busy, interesting week for me. And I always say, where does the support group leader go to support? Well, I need support just like you do. I mean, like, seriously, I do. And this is one of those weeks where, things happened, and I was in the hospital for a while. I'm fine. But there have been some important lessons that I've learned. But before we go there, let me tell you how I normally do these meetings. So I usually do about 15 to 30 minutes of some sort of educational, inspirational, encouraging discussion on whatever topic strikes. Really, really happy. Also, after that, we go ahead and take your questions. There are times when we do this for 5 hours. And there are times when we do it for an hour. It just depends really on my stamina combined with your questions. So IC is changing dramatically. And one of the things that came up this week was it's very interesting when I was getting my hair cut, actually, because 17 inches of hair gone. It feels so good. I can't tell you how good it feels. I warned you one day I'd come back with shorter hair. Anyway, I was giving all the updates on IC to one of my dear friends who cuts my hair, because I do not like having my hair cut. And she goes, so are you going to change the name of your business from IC Network or Interstitial Cystitis Network to something else? And that's really an important question, because it's very important that you guys understand that the term interstitial cystitis we have known for 20 years is not the right term. It implies that there's a problem with the interstitial layer of your bladder wall, and there is not a problem with the interstitial layer of your bladder wall. We knew that 30 years ago. We also know, based upon our new guidelines from the American Urology Association, they first released them in 2011. They updated them in 2014. They've updated them again this year in 2020, a couple months ago, that we don't even think of IC as a bladder disease anymore. We don't. It is a pelvic pain syndrome. Why? Because structures outside of your bladder are often involved in driving these symptoms. So, and we have brand new European Association of Urology guidelines. Now, and understand that the Americans are, unlike 30 years ago, when the Americans were really kind of dynamic and innovative and kind of leading thought in the IC world and pelvic pain world, it's really changed now. It's now the Europeans that are showing us the direction that we're going. They're the ones who, honestly, they got very sick of the Americans telling them what to do. I know this because I apologized many, many times to many, many different people for kind of the arrogance of the American researchers and the arrogance of American leaders. They decided years ago to create their own IC think tank. It's called the Essex Society, European Society for the Study of IC/Bladder Pain Syndrome. And they're the ones who 10 years ago said, hey guys, there's diversity in this patient population. Hi, Sandy. Hi, Barbara. Hi, DJ. And so they started subtyping a long time ago. And then we had, here in the United States, our first foray into it was the U-Point system that was created at the Cleveland Clinic, where that said, okay, yes, patients have problems outside of their bladder. So we need to look beyond the bladder. We were all very, very excited about that. But our own American Urology Association, very, very conservative. And so when these guidelines came out, it was super exciting because they finally put in writing, yeah, this is not a bladder disease for the great majority of us, that there is something else going on, that there is neuromuscular issues going on. And how do we know that? Because bladder therapies don't work for a lot of people. They don't. And if you're one of those patients who you were told 20 years ago, 10 years ago, you got this incurable bladder disease, and you're doing bladder therapies, and the bladder therapies here, hold on, I got to fix this for a second. And bladder therapies are not working for you. There's an important reason why. Because maybe it's not your bladder. Maybe if you're still flaring, despite being on Elmeron, despite doing bladder installations, despite doing hydroxyzine and Elavil, and you are still flaring, and you are getting progressively worse rather than better, and you're sitting there going, what is wrong with me? I'm doing everything they're telling me. Well, now our new guidelines say very clearly, if you're not responding to therapy, for God's sake, don't keep doing it. We don't want you to spend 10 years doing something that's not working for you, period. Period. Especially now that the most common medication that patients have been on for a long period of time, Elmeron, is now associated with pretty severe retinal disease for some patients. Okay, today we're going to take a step back from those therapies that are not working for you and revisit this diagnosis. What have we missed? What have we missed? And so this is a really exciting time because we, with subtyping, are able to heal many patients. You're going to notice I don't use the word cure because there's not a disease process happening in the great majority of patients. There's not. Instead, it's neuromuscular. So think injury, trauma instead. So what do we do for an injury or trauma? We heal it. We create an environment to support healing, but it begins with trying to figure out what the heck the injury is in the first place. So one of the papers that just came out was a patient that talked about the urinary biome. Because here's the deal. You've got frequency, urgency, pressure, pain. You're going, I have UTI. You are convinced you have a bladder infection. You find people online who tell you, yes, you have an incurable bladder disease that's driven by recurrent infection. What you don't necessarily understand is that the bladder only has two nerve groups. It's got the alpha afferent nerves, which cause frequency, urgency, and it's got the C fiber, which controls pain. Everything feels like UTI. A bullet wound would feel like a UTI. A stab wound would feel like a UTI. An infection, well, duh. A fungal infection will feel like a UTI. A viral infection will feel like a bacterial infection, right? So we just had this new biome study come out. And again, they did not find any significant difference in bacteria in the urinary tract in a patient with IC and a patient without IC, a patient with bladder pain, patient without bladder pain. And I put that on my Twitter feed a couple days ago. And so for those of you who are like going, recurring UTI, I need antibiotics. No, the data is actually showing exactly the opposite. And what the data is also showing is that antibiotic use, this was the latest one I think I put on Twitter. I don't know if I did. I think it was on Friday. when you're doing the antibiotics, you get stuck in this vicious cycle of inflammation that will never get you better. And I can pull the study and we can read the study together if you want. And so anyway, you are truly an anatomical mystery to be solved. Now, of course, whenever I'm doing these, my brain is going in all sorts of different directions because I basically have this crazy, chaotic, icy brain that loves all the research and stuff. I want to talk to you a little bit about something that happened to me this week, because I believe that when things happen to me, that it is a lesson for me to pass on. So I have shared that you all know that I care for my very elderly parents. You all know that I'm a chronic overlapping pain condition patient. And most of you know that I was diagnosed with high blood pressure about 2 months ago. Not surprising. Not surprising given the stress. I cannot change the stress I am under. My dad will be 100 in 2 months. It's hard. The stress is unreasonable. So I did everything they told me to do. I stopped eating salt. I lost weight. I started exercising. I've already did a huge walk today. And I got my blood pressure back down to normal. It was 150 over 100 steadily. Now it's in the 120s. The lowest I've gotten it is 110 over 70, but it's usually in the like mid 120s to low 130s. But I spiked over the last weekend. I had a big spike last weekend. What the hell happened? Well, I had Chinese food. I know better than that. I know better than that. I asked for no salt. They gave me salt anyway. My blood pressure went off the roof. And I woke up Monday morning with chest pain right over my heart. Now, this isn't the first time I'd woken up with chest pain over my heart. It'd been going on for months. My shoulder, underneath my arm. So I wake up Monday morning and I'm just like going, God bless America. What the heck? And I let this fester for weeks and weeks and weeks. Like I would wake up and I like felt it, a little worried. Like, what the hell is this? And my blood pressure was way up. Yes, and we do. So I decided to take myself to the emergency room. And whenever you walk into the emergency room with a heart issue, you are immediately escorted in. It's not my first time because I've inherited I get PVCs in my heart anyway. So anyway, got right in. I was there for 2 hours and they were fantastic. And the ER doc, the thing that I could tell about my chest pain is that it hurt when I touched my arm. It hurt with palpation, right? If you touch it, it hurt. So I was having pain here, I was having pain here, I was having pain here, and I was having pain underneath my left breast. So I asked him, I said, is heart pain palpable? Because you would think, when I think of heart pain, you think squeezing. I've never had squeezing. I go up and down hills every day. I never had pain with exertion, but I was having this persistent left pain and I was worried, and I'd been worried for some time. So anyway, I asked the ER doc that. It's like, is heart pain palpable? He goes, yeah, not usually, but sometimes. So let's do a workup. So they do the workup. There's absolutely no signs of a heart attack. And he sat me down, or I was already in bed with the IVs. I let a couple of students practice IVs on me. I had bruises everywhere. It was hysterical. And he said, Jill, I see absolutely no sign that there's any distress with your heart. None. But just to be on the safe side, let's do a stress test. And so Monday morning, so I drive myself home. And, we have to be strong. I mean, anybody who has multiple conditions, chronic illness, yeah, you want somebody to do it all for you, but we have to do it sometimes. So I drove myself down. I drove myself home. I was feeling pretty good. It's like, okay, I'm happy to do the stress test because I get one-on-one time with a cardiologist. Go into the stress test next morning, and I ask him the same question. Is heart pain palpable? He goes, yeah, no, not usually. So we do the stress test. I loved it, by the way. How weird is that? I had all my workout gear on. I was puffing like a beast. I made it like 7 minutes, going higher and higher. He goes, Jill, your heart's fine. There's nothing wrong with your heart. You look great. Had a little chat about other issues, like, just dealing with that. And then I go, well, then what's wrong? Why am I having this left shoulder pain? He goes, it's your neck. It's your neck. You have a pinched nerve in your neck. And so I'm like, are you kidding? Okay, good. Good. Because you worry about these things. Just like, you just worry. I had worried about this for months. This random left side chest pain. We all know I have TMJ. And so back, my first job after I got my master's degree was teaching small business classes to low-income women. I did that for a year. There's a great quote, ask, action, satisfaction. And I do this all the time on the phone with patients, and I do it myself. You cannot get satisfaction until you take action, but you cannot take action until you ask the question. And my number one rule normally is if something worries me, I'm going to ask the question immediately so I don't freaking waste months worrying about it. And I broke my rule. I let fear stop me. And I worried unnecessarily for months. So this is my take home to you, is as you think about your pain and as you think about your bladder, if you have any niggling worries about anything, don't stay at home and obsess about it, as we do, myself included. Ask, action, satisfaction. If you're worried about something, email your doctor. Ask the freaking question. See if we can get an answer to that question. What can you do that will get better? And for a lot of us, it's just having the courage to go to the doctor in the first place. Having the courage to ask the embarrassing question. Hey, doc, I can remember one of the most embarrassing questions I asked was, and I call this one of the dirty secrets of IC, and it only lasted about a year for me, was I had a painful arousal sensation for about a month. We know this is persistent genital arousal disorder. It means that my pudendal nerve was being squeezed by very tight muscles. But I was very, very embarrassed to ask about it. I also had this absolutely hunky primary care doctor. Oh my God, he was younger than me and he was adorable. I could not for the life of me talk about hemorrhoids to him. I couldn't do it. I couldn't do it. And I would see him for other things, but I would usually try to see a woman for stuff like that. And then one day I said, one day we're going to talk about hemorrhoids. He goes, Jill, I have ulcerative colitis. If there's anybody that you can talk to about your bowels, it's me. There is no shame here. At which point in time I talked to him about my old hemorrhoids. So anyway, my theme for this meeting is ask, action, satisfaction. Don't worry. Don't sit alone at home thinking in circles. What if it's this? What if it's that? Stop it. If you have a question, call your doctor and ask the question. And let's get past this into things that will give you joy. As Mary says, fear is so powerful. It is so powerful. We have to try to not let fear stop us from getting the care we need and we deserve. And I was thinking on my way to the emergency room, God, come on. I pay them a massive amount of money. I have paid them a massive amount of money for 30 years. I'm going to go use the emergency room with no shame. I paid for it, for God's sake. So anyway, that's my little thing. So anyway, let us, the only other thing that's happening, IC Awareness Month. Katie says we're here for you. Thank you, Katie. Honey, thank you. You have no idea how important that is. Uh-oh, did Facebook Did Facebook freeze? Looks like Facebook froze. Hi, Scott. Hi, Ann. Anina. Hello, Melanie. Thank you very much. DJ says Dr. J is back in Albany. Ooh, nice. Hi, Melanie. Hi, Terry. All right. So Facebook, are you guys working? Because it looks like Facebook froze. Hold on. Oh, wait. Nope. There we go. And you can hear my dad groaning. His SI joint is hurting, so he's walking up and down the hallway groaning with his cane. This is what I live with every day. How are you doing today, Scott? Let's see here. Terry says, I'm trying something new in October. Pelvic floor evaluation. Excellent. Excellent, excellent, excellent. It's so important. You know, my favorite part of my job, aside from doing these, is to actually work with patients on the phone. And the patients and to do coaching. The patients that kind of break my heart, but in the end become a very happy discussion, are those patients who, again, they've been told they have IC, they've got all these quote unquote incurable symptoms, and nobody's ever talked to them about causation. It's like you can chase symptoms forever because the symptoms are the effects. Now we have to try to understand underlying cause. What's causing those symptoms? And for this one patient who'd had IC for 10 years, pretty severe IC, you know, they mentioned several times that her muscles were tight, but they didn't explain the consequence of that. And she wanted a pill. She thought that by taking various medications, you know, IC medications, bladder medications, supplements, she thought that that was enough. But when you started talking to her symptoms, she didn't have pain as her bladder filled with urine. She didn't. And she called us because she wanted to order some more supplement. And I could, you know, it's like, okay, why are you taking that? Why are you taking Prevent? Prevent is a wonderful supplement for people with recurring UTI. And I asked her, why are you taking this? She goes, well, my best friend takes it, and she said it was really good, and she saw a really good doctor. And I went, yeah, but Prevent is for people with recurring infection. Do you have infection? She goes, no. Have you had an infection in the last 5 years? No. Then why are you taking that? Oh, because you're not like her. Does she have recurring infections? Yes. Okay, but you're not her. You don't have recurring infections. So why are you taking this? She's like, I don't know. I just thought it was the right thing to do. And it's like, okay, so let's focus on what could be the underlying cause here. So when did your symptoms start? Well, her symptoms started like in her early 60s. She was now 70, somewhere in the early 70s. And I went, okay. Was there any event that you associated with the onset of your symptoms? She's like, no, I didn't fall or anything like, I mean, I asked her if she fell. It's like, no. And I went, well, did anybody talk to you about estrogen atrophy? And she goes, yeah, man, I've got that really bad in my vagina. Like, okay. Well, do you know that if you have it in your vagina, you probably have it in your bladder too? No, she didn't know that. And so we started talking about what could be driving her symptoms. And it wasn't recurring UTI. It was just estrogen atrophy, genitourinary syndrome of menopause. And she said right there, she said, yeah, they told me I'm really dry. And I'm like, what are you doing about it? Nothing. Why? Why aren't you doing anything? She was consumed with chasing symptoms. She wasn't focusing on underlying cause. And that same is true for tight muscles, because so many of you, your symptoms began after a muscle problem, like having a baby. I was working with a lady who had a terrible injury, birth injury. She had tears into her rectum from a birth injury. And yet she had never had physical therapy, even though her muscles were so tight, she couldn't have sex and she could barely pee. So again, this is a great time because now we understand why bladder therapies aren't working for so many of you. All right, I got to fix something here on my Facebook here. Hold on. I got to pop out my chat because my chat keeps resetting. Move tab to new window. Okay, the tab is now officially moved to a new window. All right, alrighty. Ah, look at that. Now I can scroll back. Woohoo! Okay. Okay, so guys, let me just kind of go back, and you guys on YouTube, I will get to your questions in a minute. So Terry, I want to come back to you about the pelvic floor. Remember, you're having a pelvic floor assessment. The purpose of that appointment is to get somebody to study your body. They're going to look at your hips, your legs, your core, your back. The devil is in the details. Don't walk in and say you have IC. You need to walk in and describe your symptoms. Hey, I can't urinate right away. I have pain on my left side. I have pain on my right side. When I sit down, I have a vibration, or I get shooting, or I get tingling on my feet. Your job, your description will give them a roadmap of what to look at with your body. And that's so incredibly important. So they start externally, then they're going to go internal, and they're going to ask if they can do an internal exam. And for women, that is vaginal. For men, that's rectal. And they're going to touch muscles. And if they can touch a muscle and trigger your pain, that is really, 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 really exciting because they found it. And your immediate question is going to be, what are you touching? Tell me, what are you touching? I want you to be able to walk out of that appointment with the names of the muscles that are tight. Is it your piriformis? Is it your obturator? Is it your levator ani? Write it down so that you can then take that after you leave that appointment, go over to YouTube and search for how do I really rehabilitate a levator ani syndrome or whatever. Because you're going to get a lot of ideas from YouTube, especially for those of you who cannot afford physical therapy. If you can get there at least once, that's important because you'll never figure it out on your own. And if you go to a physical therapist who says, we're going to do Kegels, that is not a physical therapist who is trained correctly. Because pelvic pain patients have what we call hypertonic muscles, super, super tight muscles. The last thing we want to do is do something that will tighten them. Most physical therapists, when they're in physical therapy school, are taught about incontinence. And for incontinence patients, yes, you do Kegels, but we're exactly the opposite. We have tight dysfunctional muscles. Hands-on physical therapy. So good luck. Now, I'm going to say this. There are moments when patients get a little flustered at that first appointment because, hello, ow, that hurt. And some people will go, I don't want to go back. That hurt. Well, of course it's going to hurt. You want it to hurt. You want them to find what hurts. It's okay if it hurts. But when you go back to start the real physical therapy, this is a very one-on-one communication. They're going to look at your face. They're going to see how you're reacting. They're going to look and see if you're wincing. You tell them if it hurts. They will back off. Don't be afraid of physical therapy. Internal physical therapy is stunningly successful at eliminating symptoms, and I am living proof of this. I did bladder therapies for 20 years. Never worked. What worked? Physical therapy for me, because it was never my bladder. It was always my muscles and my central nervous system. Susan says, do you have any suggestions for a protein powder to make a smoothie? Look for pasteurized egg whites. Just whites, pasteurized powdered egg whites are great. Egg whites are also natural acid reducers, so they're good. GJ says, can you talk about getting bladder neck Botox? I get pelvic floor Botox, but Dr. Day is going to do bladder neck Botox for the first time. Sometimes the bladder neck can go into spasm. And so using Botox, this was our IC Awareness Month fact. One of our late IC Awareness Month facts is on Botox. So you can do Botox in your face, you can do Botox in your muscles, you can do Botox in your jaw, you can do Botox for migraines, and you can do Botox in your pelvic floor, and you can do Botox in your bladder. And the goal here is to try to silence a nerve that is driving symptoms or driving muscle tension. And so it's a viable option. You just have to go into it understanding the potential risks, because the challenge with Botox is wherever you inject it, it silences muscle. I mean, it silences the nerve. And for some patients, it silences your nerve that will affect your ability to urinate. And so it's not unusual for some Botox patients to come out of that needing to self-catheterize for a period of time. That's why Botox was originally in step 5 in the old AUA treatment algorithm, and then they put it in step 4 because they realized a half dose reduced that risk, but that is a risk of Botox. But Dr. Day is fabulous. Dr. Elise Day is one of our young guns. I'm really working hard to identify the next generation of thought leaders in the IC world, because so many of our veteran doctors are retiring now. And Dr. Elise Day is one of those, absolutely one of those. Dr. Martha Boone, who just retired, is also releasing a book. I got to read part of her book. It's fabulous. Okay, GJ says, I need to study about UTIs because I'm getting UTIs every other week and they culture out differently. So, DJ, for recurring UTI patients, it's very important that you track the species, identify the specific bacteria. Is it E. coli every time, or is it different bacteria every time? If it's E. coli or the same bacteria every single time, then you could have one of the super, super resistant E. coli infections. We call them superbugs. I was working with a patient a couple months ago who, on her antibiotic sensitivity testing, she was resistant to 17 antibiotics. She got a superbug. Track it over time. Now, the other challenge here is we want to make sure we do the right identification. You're a really good candidate for next generation DNA urine test, because that will give us a really clear idea of what's going on in your bacteria, in your bladder, good bacteria, bad bacteria, and of course, fungus. Let me get a drink of water here. Eva on YouTube says, can you get interstitial cystitis symptoms due to a rectocele prolapse surgery? My symptoms started after that surgery. Eva, yes. Yes, because number one, you had a really big surgery. That's a big surgery. And it was traumatic to tissue, it was traumatic to muscles, and it was traumatic to nerves. And so one of the challenges when they do prolapse repairs is getting the right tension. A normal, healthy pelvic floor muscle tone kind of feels like a raw chicken breast, just kind of soft and pliant. You can go up the length of it super, super easy. A tight muscle feels like beef jerky. It's very thick and painful. And so whenever you're having that prolapse surgery repair, the surgeon is using his fingers to try to find the right tension. And we always say, and in fact, the AUA guidelines actually say this, they want really experienced surgeons doing this surgery. This is not a surgery for a young doctor. You need somebody who's done 500 of these surgeries, because they're the ones who have the experience with their fingertips to try to find the right muscle tension. So sometimes the muscles are too tight. If you notice that you have pain when you're sitting down, when you bend over, then pain with movement, we really have to think, is there a chance that those muscles are a wee bit too tight? Some patients have had to go back in and have it released a little bit, loosened up a little bit, because the doctor just went a little bit too tight. Also, Eva, we also have to understand, I don't know how old you are, but if you are over the age of 40, you're probably in perimenopause or menopause now, which means that the loss of estrogen reduces the strength of your muscles. Your muscles are going to start to get weaker. Obviously, you had weak muscles because you had some surgery. Rectoceles, a rectocele can happen from weak muscles, but a rectocele can also happen from straining too much, right? And who hasn't strained, right? Who hasn't strained? Your doctor told you had an immune disease. Well, there is a connection with lupus Sjogren's syndrome. If you're in that group, that could affect your bladder a little bit too. But I would really want to know what the health of your skin is down there. If your vulva is dry and your vagina is dry, so is your urethra, so is your bladder. It could be that you're having some estrogen atrophy in your bladder, and that's why your bladder is a little bit more sensitive now. That's possible. It could be too that maybe nerves in the area became inflamed. That usually happens with surgery. That's why it takes several weeks, maybe a couple of months for everything to calm down and for those nerves that got so aggravated to calm down and come back to normal. Hi, Haley. Mary says, I got COVID, caused anxiety, made my symptoms of painful bladder worse, unable to go to therapy, feel like I've gone backwards. Yeah, you know, honey, I think we all feel like we've gone backwards. I feel like I've gone backwards. I think that the stress from the last 2 years has been over the top. Absolutely over the top for us. And I think that we are finite. We have finite levels of energy. We have finite levels of health, for lack of a better term. And I really feel this trust you. I feel like I've taken a step back also. You know, I teach a lot about anxiety management. My anxiety management skills are really, really good. And yet I'm struggling a lot more with anxious thoughts than I was 6 months ago. And I just think that you can only take so much before things blossom again. I'm going to start working with a therapist, I think. My goal is to calm the fight or flight response. I realize now in hindsight, now that we know chronic overlapping pain conditions is being driven by extended fight or flight. And if you don't know about that research, I'm happy to go over that research. But for those of us who have had IC, IBS, vulvodynia, fibromyalgia, TMJ, migraines, etc., we now know what causes that. That's the central nervous system. That's an injury to the central nervous system that is leaving the central nervous system in fight or flight. And of course, when you're stressed like that, you're going to tighten down muscles, you're going to irritate nerves, and it's going to intensify pain. And I realize now that I've seen all that research, and we're working on this whole new section, rewriting big sections of our website. Just rewrote our flare section. Oh my God, you guys, the flare section on the IC Network website, I just put in all the hour by hour rescue plans. Go over to the IC Network and look at that. Now I'm working on the mind body medicine part for those of us with chronic overlapping pain conditions. And it's really kicking me in the butt because now I realize that I have been in fight or flight since I was a kid. Off and on. There are moments when I'm really stable, but there are moments when I get really anxious. And I don't want to live that. I don't want to be shackled by this anymore. I want to be able to go out and do anything and not worry about it. And that's been kind of a, well, y'all know my story. I don't need to go over that again. There's a lot of trauma in my childhood because we had a very violent criminal in my neighborhood, and I was one of his victims. Okay, what is the supplement with hyaluronate? No, it is not Peora. It's Cystomend. Cystomend is and I think Bladder Builder has hyaluronate in it too. Peora is palmitoyl ethanolamide. Peora is for pain, calming nerves down. Hi, Melanie. All right, let's see here now. There we go. Becca says, one thing I've learned through having an IC is doctor visits are my visits. Exactly. You're the boss. You pay them. They don't pay you. You walk in and you direct that conversation. Worst thing you can do at the doctor is walk in and start crying. Do not do that. You pay them. They don't pay you. You need to walk in knowledgeable, informed with your list of questions saying, okay, doc, I'm here to try to figure out why I'm having this symptom and this symptom and this symptom. Don't walk in, especially to a new doctor, and say you have IC. That is a mistake. You're going to fall down the IC rabbit hole. I want you to walk in and say, I need a second set of eyes on my body to try to understand why this is happening to me. Scott says, going to go see pelvic floor physical therapy next week. Yeah, good, Scott. Excellent, excellent, excellent. The internal work seems to be helping reduce the tenderness in the rectum, which is encouraging. Yes, exactly, exactly. Good. He's using a wand. Excellent. That's excellent. so many of us have had moments of rectal pain, right? And again, one of these things where you don't want to talk about it, but it's just like, damn, I need to soak in the bathtub. And you're going hemorrhoid, whatever. Well, in a lot of cases, it's actually tight pelvic floor muscles, maybe from sitting too long. And I had this moment. Normally I'm really good, but I'm kind of passive aggressive with my pelvic floor work, my internal work. I started feeling a little rectal pain one morning. And so I was in the shower and I'm like, all right, I want to figure this out. And so I used my hands and I went down the back and I just I did not put my hands in my rectum. I did not do that. I actually was just touching muscles. That's all I was doing. So I was touching muscles kind of about an inch away from the rectum on both sides. And you know what? They were tender. And so I just used heat and I massaged them. And you know what? The pain went away. We have to learn our bodies, learn what feels good, learn what feels bad. No embarrassment. Tons of people have rectal pain just from sitting too long, which tweaks their muscles. Scott, I'd love to know the name of the wand you're using because that's excellent. Terry says she's finally better off the awful hydrodetention and you're feeling hopeful. Yes. Kayleen. All right, Kayleen, girl, can you just, as you're dealing with your day today, and for anybody having a bad day, I want you to visualize that I'm literally sitting right next to you. And I'm holding your hand and I've got my arm around your shoulder. You are not alone. You're not alone. I always get chills when I say that because I always know I'm not alone. I know this for a fact. I know that Spirit is with me. And if I can be that extra support of comfort and strength and kicking you in the butt, getting you to stand up and say, not today, you're not going to dismiss me today. Let me do that for you. Oh, so you had a few PGAD episodes. Okay. It happens. But you did get an emergency urogynecology appointment in Chicago. Excellent. Second set of eyes. Do not say interstitial cystitis. Do you think I should skip out on the next bladder installation? I don't know, hun. I can't give you medical advice like that. I think you've got to ask yourself, is it going to help? Will it make you feel better before that appointment, or would it make it difficult for you to go to that appointment? I think having that second opinion is probably more important than the bladder instill, but I can't get between you and your doctor. So you just think about it. Melanie says, a few nights ago, I was in so much pain, nothing would stop it. I walked the floor and cried. Nothing would help. I was afraid to go to the ER because I had no idea how to explain what was going on. I felt like they would assume that I just wanted pain meds. Melanie. So this is my rule. My rule is if I'm afraid, if I don't understand what the hell is going on with me and I'm in pain, I go to the ER, which is what I did on Monday because I thought I was having a heart attack. I didn't know I had a pinched nerve in my neck. And so it's always okay to go if you need help. But you have to prepare yourself for that appointment and prepare with what you want to say. You have to remember that emergency care is really about life-threatening care, right? They don't do chronic stuff. Like when I tried to talk to the ER doctor about blood pressure medicine, he goes, I don't do that. I don't do that. And, Jill, your blood pressure is fine. I don't think you even need to take anything, but I can't engage in a discussion with you on that. I'm here for your heart. So the advantage of an ER when you have pelvic pain is that they can rule stuff out. So they can rule out active UTI, especially if you have blood in your urine or fever. That's important because we don't want that infection to go up to your kidneys. So that's a valid reason to go to the ER. They can rule out appendicitis. We've had a number of patients who thought they had appendicitis when it was actually just a wicked pelvic floor flare or IC flare. What I would want you to do is I would want you to write down your symptoms. You know, there are some moments when pain is so severe, and I remember it happened to me on July 4th, 1993. I'll never forget that day. I couldn't sit, I couldn't stand, I couldn't lay down. The pain was so severe. 4th of July. All I could do was pace, and I was bawling my eyes out. Absolutely bawling my eyes out. The pain was so severe. And I mean, that's when that's when I think you go, because that was actually one of the first times the local doctor actually gave me pain medicine. You know, honey, big hug. I'm so sorry that you had a night like that. Becca says, I have to get tested monthly for UTIs, but I can't tell the difference between UTIs and flares. I just wrote a big article on this, hon. I just wrote a really big article on how to tell the difference between a UTI and a flare over on the IC Network website. Let's just go through it. So they both cause frequency, urgency, pressure, pain. UTIs can cause visible blood in your urine. UTIs are notorious for causing burning while you're peeing. IC does not normally do that. The bladder does not normally do that. Estrogen atrophy will do that. But for the great majority of quote unquote IC patients, you don't have burning during urination. UTIs can cause fevers. IC does not cause fever. So fever, maybe shooting pain up by your kidneys, burning while urinating. So what do? You get a UTI home test kit. Here, hold on. Let me get mine. Where is it? Here it is. Is this it? Where is it? Hold on. I got to find my UTI test kit. Oh, here it is. Okay. Okay, so, I think my first year, I thought I had UTI every single flare. And I can't tell you, I mean, we all need stock. We all need stock in cranberry, which of course is terrible, and in companies that make stuff like this, because we're all thinking UTI, UTI, UTI. Well, it's not UTI. So really, the first thing that you should do, Becca, is you need to invest in some UTI test strips. These are from Walgreens. I buy I have to do it with my elderly parents all the time. So I usually buy 4 or 5 boxes at a time. That's 3. There you go. And there is a little stick inside that you pee on, and it has 2 pads on it. And the pads will change color if you have UTI. The top pad is for leukocytes. The bottom pad is for nitrites. If you have a double positive or you have positive nitrites, you have infection, because nitrites are only produced by bacteria. But if you have positive leukocytes, that could just be a flare. That could be a flare from eating something that you shouldn't have eaten, especially if you have estrogen atrophy or Hunner's lesions. A lot of people ask, why do I have white blood cells in my urine? Doesn't that mean UTI? And it's like, no, it doesn't. It does not at all mean that you have UTI. What it means, let's look at this. So here's a 3-dimensional picture of the bladder, right? So the bladder, we've got the protective coating, the gag layer up here, the mucosal layer up here. Whoops, hold on. Then we've got the urothelial cells, which is the skin. These are the cells that keep urine away from your nerves and your blood vessels, right? So the mucosal barrier prevents bacteria in your urine from reaching these cells to infect them, and it affects irritants in your urine from reaching these cells. But look at what happens. If you don't have your mucosal layer for one reason or another, let's just say estrogen atrophy or chemical injury, chemotherapy that's kind of burned your skin and inside your bladder, now these irritants in your urine, they go exactly where they're not supposed to go. They go down to the urothelial cells. Now, the urothelial cells are interesting because you think that they're passive. It's just like skin, right? It's just skin. It's just a layer. Well, these urothelial cells have a way of communicating to your immune system, invader, invader, help, help. So now we have an invader. It's gotten into the cells. The cells are sending an emergency alert out to your body saying something's here that's not supposed to be here. Your immune system reacts by sending white blood cells to the area through capillaries, through the blood vessels. So the white blood cells swarm to the area because they think that they're fighting an infection, right? So here they are, they're in the blood vessels. But how do the white blood cells, which are your army, I should post some videos so you can see how white blood cells actually devour and eat infection. So you got the white blood cells that are swarming down here. How do they get here? How do they get up here? Your blood vessels open. They open and they release them. And so that's why we tend to have leukocytes floating around in our urine and even red blood cells in our urine. Most of you probably have had microscopic blood in your urine. Okay, that doesn't mean you have infection. It just means that we've got something happening there. So anyway, positive nitrite, that's definitely something that means that you have infection. Positive leukocyte, probably just a flare. Double positive, you take a picture of it, email it to your doctor. Hey, I think I have a UTI. Here's my dipstick test. Make sure that they will order a urine culture so that you can go and pee in a cup and get them to identify the bacteria, because we need to know what we're treating here. No guessing anymore. There's no we don't do broad spectrum antibiotics anymore. They shouldn't do that over the phone because we're really trying to stop drug-resistant infections. Becca says, I had trouble too. Now though, I know that if a UTI, if my urine is cloudy, it's the only way for me to distinguish. That's interesting because I have moments when my urine is quite cloudy, but it's never UTI. All right, Facebook, I can see you're having some issues here. Okay, hopefully that's better. The stream gets it weird. Mary says, doesn't atrophy cause UTIs too? Yes, because when you have atrophy, you've lost some of this coating. And now this gives, the door is open for bacteria to infect these cells if you're dry. That's why moisture is so important. We need this nice, thick mucosal barrier to protect that skin down there. Charlie, hey Charlie, what do you feel causes IC in men? Okay, so dude, and I say that with love because I call my nephews dude, so don't take that the wrong way. Here in my office, 90% of the men that I work with have injury, by far, probably more, might even be 95%. And so we're looking at pelvic floor muscle injury, riding bicycles, riding motorcycles, playing football. If you were in the service, if you ride a desk and you're sitting for long periods of time, that's going to affect your muscles, which is going to eventually affect your bladder and so forth. So the great majority of men that we work with, once you get on the phone with me, because my first support group was filled with men 30 years ago. And so I that's kind of my specialty, actually, is working with men, because y'all are so freaking quiet and you need support. And so I am an open door for men who are struggling with IC and pelvic pain. Absolutely open door. Always really make an effort to take extra time with the men because you don't have the support that women do. And I want to make sure you have an opportunity to be heard and to get some new ideas. Just know that in our new AUA guidelines, they describe 3 distinct groups: bladder wall driven, Hunner's lesions perhaps, pelvic floor driven, which I believe is the vast majority of men, and or chronic overlapping pain conditions. So these are the patients who have multiple pain conditions, and we know now that that is a central nervous system injury, and we know how to work with that. Jennifer. Okay, you guys, I am 26 minutes behind on Facebook with your questions. I apologize. I can talk forever about this stuff. I'm having the worst flare that I've ever had. Went to urgent care. She ordered blood work. They discharged me with five Valium to go back to the hospital tomorrow. Still having pain after taking one. You are understanding. What would you do in my case? You're 73 years old. Well, so Jennifer, it's all about when is your pain the worst? Is your pain the worst before you urinate or after you're done peeing? So when is your pain the worst? As your bladder's filling with urine and you feel better once you pee? Or is your pain worse not before, but after you're done urinating? If it's worse before you urinate, then we got to rule out UTI and maybe Hunner's lesions and or something else that could have triggered your bladder wall. And so the advantage of going to urgent care is they're going to take that real seriously. If it's after you're done peeing, we're really going to look at muscles. And we also, guys, every single one of us have to understand and embrace that pain triggers anxiety. Of course it would. Of course it would. But then the anxiety reinforces more pain. So if you can, grab a heating pad, lie down, get in your recliner, put on some of your favorite music, watch something funny on TV, your favorite old movie, and just try to take some deep breaths. Let's just try to calm everything down. You've done this before. We've all got, you guys, the problem with an IC flare is as soon as it happens, you're going, oh my God, this is it. I'll never get better. And flares are short term, and you can't let yourself jump off the runaway train of emotion. That's what a therapist taught my support group is that, okay, pain causes an emotional reaction. There's no doubt about that. But if you have pain every day, that every time you ovulate, do you have to get all upset about it every single month because you know exactly what it is? Or can we just take a step back and go, okay, that's my ovulation flare, no biggie, not going to worry about it. I know it'll be gone in a day. That's why doing avoiding diary is so helpful, because it allows you to track patterns, because there can be patterns in flares, and we have to learn. We have to learn what those patterns are. But big giant hug, honey. Big giant hug. Ann says, does Pure have hyaluronic acid? No. Mary says, I'm so scared that I have to have one. I'm in pain. Are you better for having it? Oh, that's a hydro. Thank you. Thank you, guys. Thank you on the hair comments. My urologist said D-Manus and aloe vera can cause biofilm. Have I heard this? D-Manus can cause a biofilm? That doesn't make any sense. D-Manus is a simple sugar that the human body does not use. So when you take mannose, you immediately excrete it and pee it out. The advantage of D-Manus is it has a receptor that matches a receptor on E. coli. So if you're struggling with recurring E. coli and you got E. coli in your urine, you got D-Manus in your urine, they attach and you pee it out. I've never heard of that causing a biofilm. And with the aloe vera, you know, the bladder wall does not have plant in it. It's a plant. Aloe vera can be soothing. Aloe feels good on a burn. Aloe for some people feels good in the bladder. We have aloe. I personally love Aloe Path. That's the aloe that we suggest because it has organic anthraquinone-free aloe, but it also has PEA in it to calm nerves down. So it's like a double whammy of calming. But I've never heard anybody say that either one of those can cause biofilms. Sally says, my white blood cell count and my blood tests have been high. Could this be due to IC? I don't. If you have Hunner's lesions, maybe. But that's really kind of a sign of maybe a systemic infection also. They really need to take that seriously. You guys, if you have doctors to recommend, could you please email me their contact information, icnetwork@mac.com. You know, we have a doctor list on our website that we're constantly trying to update, and it's really, really important to update it. Mary says, it's next generation DNA testing accurate, though? It's a hell of a lot more accurate than a culture. Well, so Mary's bringing up a really good point here. She goes, is next generation testing accurate? I heard our bladders are not sterile, and most urologists don't believe in microgen because they say even people with no symptoms have bacteria show up. Okay, so number one, your urine is not sterile, just like your stomach is not sterile. Remember years ago, a doctor in Australia was able to figure out that there was a bacteria, Helicobacter pylori, that lived in the stomach acid of the stomach and caused stomach ulcers, and they treated him terribly for 15 years until they were finally able to prove it. That bacteria can live in very adverse situations, and so there are a number of bacteria that do live in urine, and they're supposed to be there. They play an important role. They play a very important role in the bowel and in the bladder. So the problem with urine cultures, a urine culture, now this is what I did my senior project on when I was getting my pharmacology degree, was the isolation of drug-resistant bacteria at my local university and our local hospital. So you take swabs of whatever you're testing, and then there's a petri dish that's round like this. And inside that petri dish is a growth medium. It's food. It's food that bacteria can eat, that some bacteria can eat. So you prepare the petri dishes, you give it time, it gets solid. It's like Jello, right? And then you let it solidify. Then you take a swab and you put it across the petri dish. And then you wait 24 hours to see what grows. So the problem with the petri dish urine culture technique is bacteria eat a lot of different foods. And so it will only select out the bacteria that will eat that specific food that you've used. And so there was research like 2 years ago that said that urine cultures actually miss like 90% of the potential bacteria that could grow, aerobic, anaerobic bacteria, et cetera. So the advantage of next generation DNA urine testing is it gives you a snapshot of everything in your bladder. Good bacteria, bad bacteria, and most importantly, fungus. Because we now know that some patients who have severe bladder pain have candida infections in their bladder. And it was our own National Institutes of Health who discovered that 5 or 6 years ago. So a next generation DNA urine test, it's data. It's just data. It's a snapshot. Good stuff, bad stuff, bacteria, virus, even viral, if you order a viral test. But it is the penultimate urine test, and the urine culture is eventually going to go away. We had a presentation last year at the AUA in which the keynote speaker said, you know, the days of doing urine cultures are numbered because next generation DNA urine tests are so good. And they are incredibly good. They're hard to interpret, though, because you have to figure out what's good bacteria versus what's bad bacteria. If you're 99% E. coli, that's bad bacteria. But there are some bacteria that are meant to be there. So it takes an educated doctor to really understand the results and to interpret the results. What I like about next generation DNA urine testing is it identifies antibiotic resistance genes. So this is what the infectious disease specialists are using for people with really severe complex infections. They don't waste any time doing cultures. They go right to next gen because they need to look at antibiotic resistance. And there are huge databases at the Center for Disease Control and the National Institutes of Health that they use to match the DNA profiles they've collected with what they're seeing to help us understand. So I, for example, every time I've been tested, I come up with the same antibiotic resistance gene, which is an amikacin gene. Amikacins are a type of antibiotic. I have never in my life taken amikacins. Never. Unless they gave it to me as a kid, I have no history. I mean, I have a degree in drug development. I know the drugs I've taken. And so the question is, how did I get this really obscure drug resistance gene? And I think it came from food. I think it came from eating chicken or beef that had been treated with amikacin. Scott said, I've been using a vibrating wand from Intimate Rose. Oh, you know, I just ordered some from them. I think it works quite well. I've been using it every day, and it seems that applying 2.5 minutes or so on each tender area. Scott, that is so cool. Because that's how much time, when I have a tender muscle, that's what it takes. It's about 2.5 minutes of rubbing on that muscle down there to get it to release and relax. Let me make a note here, because I would love to get a demo for that. Your pain has gone down 90%. Yes, good. Okay, Intimate Rose. Vibrating wand. All right. I got to look at that again. I love that. Thank you for sharing. Melanie says, hydrodistension only helped for a few days and you were right back into a flare. Exactly. Remember, hydrodistensions are what we call a destructive therapy. There's destructive, which means it's a therapy that's killing something, or there are constructive therapies that are building something. The reason why hydrodistensions give you kind of a false sense of wellness is because when you stretch the bladder, you break the nerve, but the nerve always grows back, See, my neck, like seriously, is so tight. Massage break. Just feel it zinging me. You guys, you can always tell if my neck is tight because I get a tremor in my neck. So if you ever see my head doing this, that's just my neck is tight. It goes all the way back to I got rear-ended really badly when I was 22 years old. That's when it all started, 40 years ago. Melanie says, I have rheumatoid arthritis, fibromyalgia, vulvodynia. I'm thinking that this is attributing to the bladder pelvic pain. Yeah, it could be. It could be, hun. Melanie says, I'm so sorry, sweet friend. I've been dealing with this for the past 10 years. My flares are awful. I now know more than my urologist does. LOL, he even told me that. Thanks to Jill. That's a success story. If you can walk in and know more about your options than your doctor, embrace your power. Diane says, my bladder's gotten worse since COVID. That's very common with COVID. We call it COVID cystitis. The IC Network is doing research with COVID cystitis right now. We were able to help prove that does happen. And specifically in the IC patient, a COVID infection causes a flare, and it can have a flare that is non-responsive to any of our typical flare management strategies, and the flares can last 3 to 6 months after COVID. DJ says, does anybody have a flare after pelvic floor physical therapy? That's not unusual, but what I would say is you need to talk to your physical therapist about that because they might be pushing a little bit too hard. For me, when I have physical therapy, maybe for a half an hour, 45 minutes afterwards, I'll feel tender, and then like on the drive home, but then it gets better. Thank you, Scott, for the 50 stars. Much appreciated. For anybody who appreciates these meetings, Please think about coming on over to the IC Network and signing up for our free newsletter. I don't abuse you with those newsletters. I'm very careful about what I send out. And you can become a member and get our wonderful magazine, the IC Optimist, and all sorts of stuff like that. Man, I'm working on so much stuff right now. I got so many ideas. Kayleen says I want an ice pack so bad right now. My bladder lets me wear jeans, but that C word, yeah, honey, I know. Melanie said I was a budget officer at the U.S. Embassy and sat for 7-8 hours. That's when this started. Yep. So pelvic floor combined with estrogen atrophy, hun. Kim says, horrible constipation is giving me bad pelvic abdominal discomfort. No laxatives are working. Also a burning sensation in the lower abdomen, a symptom of pelvic floor. Kim, I would want to know where the burning sensation is. And, I have no shame. I'll talk about anything. To me, a fleet enema is life-changing. If you're struggling with what we call packing, where you've got a lot of stool sitting in your rectum and it's just not moving, or you feel like you've got something hard in there that's not moving, that's when you whip out a fleet enema, my friend, and it takes care of it in 20 minutes. I had to do, after my hysterectomy, believe me, about 4 days later, that fleet enema worked like a charm. Scott says he used a non-vibrating wand for a while, but I think the vibrating wand is more effective in getting rid of the muscle. It wouldn't surprise me at all. Jeannie says, I had 300 lesions fulgurated 7 weeks ago. Felt better for a while. Then last Saturday, I was peeing blood clots again. Crap. I'm in pain again. With the lesions come back that fast, we just moved, and I'm seeing a new urogyne, and I'll probably need another cysto to see what's going on. This has been a long journey, and it's been so painful. Wow, 7 weeks? Well, when you have blood clots in your urine, that is an emergency. That is an emergency. You need to call your new doctor immediately. You need to get seen immediately because they need to figure that out. Because you could have a post-op infection. I mean, a nosocomial infection happens. Nosocomial means hospital acquired. So you were in the hospital, you had an outpatient procedure, they had a cystoscope in your bladder, God knows whatever else. That is a ripe opportunity for you to have picked up one of these super drug resistant, very insidious hospital infection. And it may have just taken 7 weeks for it to get to the point where the damage is so bad it's making you bleed. I absolutely would be if I were peeing blood clots, I would be at urgent care. I do not believe that should be taken lightly at all. Kayleen said, I went to the ER Thursday night. You only got Toradol. I think she could have given me a lidocaine topical into my urethra with an applicator. I'm going to head back into the party. Okay. Lisa says, I'm using Eucora products. I have Hunner's lesion. Oh, honey. Oh, no. The challenge with the Eucora products for some of us, especially for patients who have Hunner's lesions, is that they're just acidic. So you would literally be my very first success story of an IC patient using Eucora. But because you have Hunner's lesions and severe pelvic floor dysfunction and pudendal neuralgia, which has nothing to do with bacteria, and vulvodynia, which has nothing to do with bacteria, I wouldn't be putting a lot of money in that. I would be putting money into working with those muscles with physical therapy and getting those lesions treated correctly. The new AUA guidelines, they only have 2 recommendations for treatment. Number 1, if a patient has Hunner's lesions, those lesions should be treated immediately. No more sending somebody home for a year and not getting treated. If they find Hunner's lesions, they are supposed to be treated correctly with lesion-specific therapy at the time that they find it. Lesions do not respond to Elmeron. Lesions do not respond to bladder installations. Lesions require lesion-specific therapy, which is fulguration, laser therapy, steroid injection, or maybe hyperbaric oxygen therapy. So don't think that your Eucora is going to fix your underlying problems. It's not. It's not going to fix tight pelvic floor muscles. It's not going to fix pudendal neuralgia. And it's not going to fix Hunner's lesions. My concern would be that it would be making them a bit worse. Also, if you say you suffer from UTIs and severe yeast infections, a next generation urine test to me would be very, very important, because the next generation test will help us understand if you have yeast in your bladder. Because again, it was our own National Institutes of Health who found that some patients with severe bladder pain have bladder pain because they have candida in their bladder. I had candida for 2 years. I had a super drug-resistant Candida glabrata. And I got it after doing antibiotics for 3 months back under the old Dr. Fukuzawa protocol that we all did 25 years ago. You know, that was when they thought we all had embedded infection, and we all sent our urine off, and they almost always came back positive for something, Enterococcus or Micrococcus. And so we all did long-term antibiotics. And I brought it to my urologist, and I said, here are my test results. Will you give me antibiotics for 6 months? He goes, no, no, that's going to do a lot of damage. I'll give it to you for 6 weeks. And we extended a little bit. So ultimately, not only did it not help me, but what it did do is cook a very, very dangerous Candida glabrata infection that was completely drug resistant. It took 2 years to get rid of it. And whenever that Candida flared, I mean, listen, if you flare when you eat sugar, if you flare when you eat ice cream, if you flare when you eat sweets, you have to consider that you could have a Candida infection in your urinary tract. Hi, Gay. Hi, Sherry. Thank you, hon. Yeah, 17 inches is gone. Yes. And I'm very proud of myself that I did that an hour after leaving the emergency room. You're welcome, Katie. Katie says, can you discuss the irritable bowel connection with IC? Sure. I mean, I had IBS years before. So I had frequency urgency in seventh grade, 8th grade middle school. I had vulvodynia in high school and junior college. I got IBS in my 20s, and not little IBS. I'm talking bend over and screamers. Like literally every day at 11 in the morning for 3 or 4 years, I was laying in the fetal position on my bed or in my bathroom floor because I had terrible bowel spasms. Like you can't walk kind of bowel spasm. They were that bad. And of course, you go to the doctor, and the doctor is like, well, you're just not eating enough fiber. You need to eat oatmeal. Believe me, I was eating like oatmeal like there was no other food. I ate oatmeal every meal. I had oatmeal in the morning. I made oatmeal cookies, oatmeal bread. I put oatmeal on salads. I did everything I could to get rid of this freaking IBS, and I just got worse and worse and worse. And it was very debilitating. I mean, this went on for years. Even when I was in graduate school, this was going on. Then my sister gave me this book. This book changed my life. This book changed my life. Because this book said, it talked for the first time about food sensitivity. That it's not an allergy. An allergy provokes an allergic reaction. Your throat swells. That never happened to me. A sensitivity is basically that your body cannot break it down for one reason or another. Your body is sensitive to one of the byproducts of it. And so what this book taught me, and again, this is a very, very old book from the 80s. I think I got, from the 80s. It said, well, first thing you want to do is stop dairy. Okay, stop dairy. That helped a little bit. Wasn't having the cramping mucousy pain. The next thing it said was, okay, stop all your grains for a couple of days. No, you can have rice. That's it. Stop everything else. Well, as soon as I stopped the oatmeal, the cramping stopped. Oh, light bulb. Guess what? I happen to be personally sensitive to oatmeal. Oatmeal is, and there are quite a few IC patients who have oatmeal intolerance because I've worked with you over the phone. So, concept number one with IBS is that for those of us who have multiple pain conditions, we have a very sensitive nervous system. The nerves in our bladder are sensitive, the nerves in our skin are sensitive, the nerves in our brain are sensitive, and the nerves in our bowel are sensitive. And so we have to try to figure out if we're exposed to foods that trigger that sensitivity, like oatmeal was for me. And then we have to work on calming nerves down. There's a great website, helpforibs.com, run by Heather. And Heather and I got started literally the same year. She did IBS support, I did IC support. She created a product line very, very quickly that we have in the IC network. Heather's Tummy Fiber. Her products are amazing. I use them myself every day. I've got Heather's Tummy Fiber right here in my smoothie. That's fiber for people who have IBS. One of the things that she taught me is that when you have a very sensitive bowel, there are some fibers that are irritating. So before I talked to her, which was in 2006, because she spoke at our 2006 IC conference, I was eating a lot. I was trying to eat a lot of fiber. I was eating a lot of like wheat bread and stuff like that. I was miserable, but and cereal and stuff like that. And yeah, I was having bowel movements, but they were painful. Angel here says she's very sensitive to oats. You are not alone. Isn't it great to talk to other people who have exactly that same food issue? So what she explained to me at our IC conference is that there is a insoluble fiber as compared to a soluble fiber. A soluble fiber is a fiber that dissolves in water. It's a very gentle fiber. And the perfect example of a soluble fiber is a pea, green peas. Very soluble, very, very gentle. As it goes through your body, it's soothing. An insoluble fiber is like granola. It's hard and it has rough edges. And the problem when you've got a sensitive nervous system is if you eat a lot of granola, literally as it's going through your bowel, the rough edges are irritating the nerves. And it's very hard on your gut. And think about Metamucil for a moment. Metamucil is psyllium husk. And of course, everybody says, well, psyllium husk is great. Why don't you use some psyllium husk? Well, I had problems with psyllium husk. I didn't feel good when I did psyllium husk. I'm fine with acacia fiber or peas. And she explained that psyllium husk is half insoluble fiber and half soluble. Psyllium husk is actually kind of irritating to a sensitive bowel. Understand too that the way my IBS presented was, again, it was very food sensitive. I rotated between IBS diarrhea, IBS constipation. I would normally have an IBS flare after eating a salad or eating Chinese food. And there's nothing worse than going on a date with a hunky man and ordering salad first. And 30 minutes later, as you're trying to have this nice conversation, the spasms hit. And you have to go home. And the guy's going, what's wrong? And you're too embarrassed to tell them what's wrong. I mean, that happened to me. Paul, I'm sorry. You know I love you. If you're watching this. He's an old friend of mine. So what Heather says is you never start a meal with an insoluble fiber. You want the first food that goes through your gut needs to be soluble. It needs to be gentle. So if you want to have a salad, fine, but have it at the end of a meal, not at the beginning, because lettuce has sharp edges. Lettuce actually is irritating to the gut. It would be better to start your meal with a soup or a roll. So anyway, helpforibs.com is a great website. Angel says you can't do psyllium huzzah. Angel, isn't it? It's just so cool. You're my sister. You're my bowel sister. And the thing is I mean, when all this was happening in my 20s, I was just so confused. It's like, what next? IBS, migraines, whatever. And you feel like you're failing at life, and you feel like you're failing your family, and you're failing yourself. And I was profoundly depressed in my 20s going through all that. I didn't understand it. Now I totally get it. And most importantly, I know it was never my fault, and it's not my fault, and it's not your fault. You have done nothing wrong. I did nothing wrong. I was born with an oat sensitivity. And I can remember getting sick eating oats when I was a kid. We just didn't put it all together. No shame, no blame. You have done nothing wrong. You're hurt. You're hurt. The great thing about going to a support group, especially an in-person support group, is that when you walk into that door, you get to see beautiful, normal people who are in an abnormal situation. They've been hurt, and it completely changes your brain, because before you go, you're thinking that everybody can see it on your face. You're thinking that you're damaged goods, that you're abnormal, until you go to a meeting and you see 20 other people and you go, God, wait a second. She's totally normal. We are hurt. We are injured. And that's just an important mind shift. I remember I did my first IC conference in 1994. And we had like 200 people there, and I was the MC, and I walked up to the podium. And it was just so wonderful to see that we are normal people in an abnormal situation, and that there's nothing fundamentally wrong with any of us. We've just been hurt. Or you could have pelvic congestion syndrome, or you could have this or that. But I want to change your mindset. I don't want you to think you're damaged goods. I don't want you to think it's your fault. It's not your fault. You're just hurt. It'd be a hell of a lot easier for your elbow. Everybody understands elbows. Like, you broke your elbow. Okay, we get that. You can't lift anything. Of course, you broke your elbow. The problem with a broken pelvic floor or an injured bladder is nobody can see it. And it's hard to explain, right? Lisa, thank you for the 200 stars. Thank you so much. Scott said, peppermint oil tea has helped me have better BMs as well as extra virgin olive oil. Excellent. Peppermint is a proven anti-spasmodic in the bowel. It's very good if you're going to have a colonoscopy, to have a strong cup of peppermint herbal tea before your colonoscopy, because it keeps your bowel nice and calm. Marlia says, oh, great. I just ate a Metamucil fiber cookie this morning and half this afternoon, along with a small salad, because I have a hard time going. Oh, Marlia, I'm sorry. So peas are a much better choice. Peas are a much better choice. You need to be eating 20 to 25, women need to eat 20 to 25 grams of fiber a day to have healthy bowel movements. Men need to eat 25 to 30 grams of fiber a day. So what you really have to do is you have to look at a fiber chart. So I thought eating salads was a lot of fiber. I mean, when I was working with the IBS doctor, she said, how many grams of fiber do you eat a day? I went, I have no idea. Nobody's ever asked me that question. I said, I'm sure I'm eating plenty. She goes, I double dog dare you, prove it. Go home and look at the labels and count it up. I went home, looked it up. I was eating 6 grams of fiber a day. That's it. It's no wonder I was struggling. Thank you, Deborah. It's no wonder I was struggling with very painful bowel movements. That was what I call my marble phase. Like you're trying to pee hard marbles, right? You know what I mean. You know what I mean. And so anyway, yeah, I wasn't even coming close to eating 20 grams of fiber. I was eating 6. So I found a wonderful fiber chart online. It was produced by the state of New York. And what I learned is that a cup of lettuce has 1 gram of fiber in it. One, that's not enough. A cup of peas, 13 to 16 grams of fiber. So don't think you're getting a lot of fiber eating a lettuce. You're not. You're going to get a lot of fiber if you eat peas or beans. Although I have to tell you, oh my God, this is so, so funny. So, when you care for elderly parents, it's all about peeing and pooping. That's our days. It's all about peeing and pooping in my home with very, very elderly. My dad will be 100 in 2 months. So my mother, we haven't had a lot of salads in the last couple of weeks. And so the other night, my mom goes, I really need a salad. Can you get me a salad? So I went down to our organic market and believe me, I made her a salad. It had garbanzo beans. It had kidney beans. It had peas. It had corn. It had lettuce. It was the equivalent of a fiber bomb. Then I made my own because I don't do lettuce. So I did carrots, beets, peas, garbanzo beans, a few things like that. Well, bomb was literal the next day. Oh my God. And she has arthritis, so she can't use her fingers to clean herself. So guess who had to pay the price for the fiber bomb salad? All I can say is thank God for Preparation H wipes. So a little goes a long way. A little goes a long way. I just put way too much, and I put way too much on her salad. You gotta laugh at these moments. Christine says dark chocolate makes me have frequent bowel movements. Interesting. Chocolate gives me spasms. It gives me bend over and screamer spasms like oatmeal does. So I don't eat chocolate at all, but I do eat carob. I love carob. I can't have it in my house because I'll inhale the whole thing, which sucks. But we normally have carob candy in our shop. We can't ship it in the summer because it melts, but we're getting into fall now. And so we will have carob again in the IC Network store, hopefully sooner rather than later. Really good carob candy, coconut almond sea. Oh, damn it. Coconut almond sea salt, and I can't have the salt. There's a really good carob peanut butter and jelly truffle. Thank you, Melanie. Marlia says, what's the fiber in my drink? It's acacia fiber. Yep. Heather's tummy fiber. Let me go here. Hold on a sec. I'll show you. Hold on. Okay. So we have the tin, but we also have a big refill pouch. So I just keep mine in a bell jar in my kitchen, right? And it is, it's just powdery, right? You can see it's the consistency of sugar, actually a little bit smoother than that, right? And so let's just, so here I've got some water. Let's put it in the water. So it doesn't get all slimy like Metamucil. With Metamucil or psyllium, you're just kind of gagging, trying to get it down. It's so slimy. This, for the most part, is water soluble. There's no taste to it at all. You can put it in hot water. You can put it, if I'm making a latte, I'll put it in that. And sometimes to kind of help it. So you can see mostly it's dissolved, right? It's fine. Tastes like water. It's fine. There's no flavoring in it, no coloring in it. I don't want to do too much because I don't want to have my own bowel bomb, because Rhonda says you love Carob, your favorite. You know this, so Yes You Candy Company is a company that we get our Carob from. Their Carob factory burned down last spring. And so they finally rebuilt it. And I think we're going to be able to order it in the next week or two. They have the most amazing Carob brownie mix. And you know who else has a really good Carob brownie mix, or a Carob recipe for brownies, is Bev Lauman. And I think you can find it on the IC Network website. Hold on, let me look. I mean, Carob, 30 years ago, Carob looked like dried up chocolate chips with white on it, because it's not like that way anymore. Carob is as rich as chocolate is now. We gave it to the teenagers in the family. We gave the candy. They had no idea it wasn't chocolate. So let me just come to the IC Network, go to the IC Network website. Let me see if I can find it. Hold on. I have an article here. Does chocolate irritate your IC or IBS? Yeah, here it is. Yes. Okay, so if you want the Carob brownie recipe, go over to the IC Network website, icnetwork.org, and just search for chocolate. And there's a whole blog, Does Chocolate Irritate Your IC and IBS? And we go through all of the options, and we show the Missy J's. And I've got the recipe for Carob brownies, peanut butter and Carob cookies, Mexican hot Carob cocoa instead of hot chocolate. You can do hot Carob, and a fake mocha latte with Carob chips. Nice. Okay. Carol says, so glad you're on every week. Well, I try. I've been inconsistent, but I try. They have me taking Mirabitric 25 milligrams, just took 2 for 2 days. It's made me so nervous and shaky. I will not take them. Well, so let's talk about Mirabitric for a moment. So when we're trying to calm the nerves down in the bladder, remember, it's nerves, the alpha afferent nerves, which are driving frequency urgency. Okay, and it's the C fiber nerve which is driving pain. And so the reason why they often suggest that you do like ditropan or Detrol is because that can help calm bladder spasms down. And the reason why they would have you do Elavil, a low-dose antidepressant, is because that calms the nerves down. Of course, the problem with those medications is that they're anticholinergic medications, and anticholinergics have a very strong link with dementia now. And it's not just older people, it's younger people too. And so we have issues with a lot of the traditional medications that have been recommended for IC. They have a lot of side effects. Some of them are quite daunting side effects. So there has been a move. Once that cognitive decline research came out, there has been a very steady move away from the anticholinergics, because we don't want you to do that medication every day for years. I think what the research showed, don't quote me on this, but I know the research is on our website somewhere, that if you take it every day for 3 years, that is a significant risk increase, an increased risk in the development of dementia or cognitive decline. So Mirabitric does not carry that same risk. So Mirabitric is now the go-to medication. So, Carol, this is what I want you to think about here. You took 2 for 2 days. Is 2 too much? I can remember the first time I took a Vicodin. I took a whole Vicodin and the room started spinning. But it was not an allergic reaction. It was just too much. So the next time I took it, I took a half a pill and I was like, oh, good. The room is not spinning. This is a good thing. And it was helping my pain. That's an even better thing because I was in a lot of pain back then. Then I tried a quarter of a pill. And the quarter of the pill was the sweet spot for me. The quarter of the pill nipped the pain, no side effects. But you can't do that with every medication because some medications are time release. And if you cut them in half, you can overdose because you're interfering with the way the medication is being delivered. So this is what I think you want to do. I would suggest that you call your doctor and say, listen, you tried the 25 milligram, way too strong, made you very nervous, very shaky. And also pay particular note to heart rhythm. Did it make your heart race? Did it give you an irregular heart rate? Some medications can do that. And for that reason, a medication that might not be the right medication for you. But if it just made you nervous and shaky, then see what your doctor says about reducing the dose. Instead of 2 pills, it might be viable to do 1 pill. Or I don't know if you can cut it in half or not. I have no clue. Do not rely on me for that. You can look at the pill. If it has a score down the middle, that's kind of a clue that you might be able to cut it in half. But don't do it just because it's there. Talk to your doctor. Talk to your pharmacist first. It just may be that 25 milligrams is hard. You know, we see this with Elavils, and in fact, they talk about this in the new IC guidelines. Elavil is a low-dose antidepressant that calms nerves down. You should never be offended if somebody suggests Elavil. They're not saying it's all in your head. They're actually acknowledging that you're in pain, and they're acknowledging that the nerves are causing the pain. Elavil is a go-to in any good pain clinic. The problem with Elavil is that the higher the dose, the more effective it is. The problem with Elavil is the higher the dose, the greater the side effects. And there are a ton of side effects with Elavil. Dry mouth, dry eyes, irregular heart rate, weight gain. You get sugar cravings like mad. Like I was on Elavil for 3 months. I gained 20 pounds. I lost it as soon as I stopped it. But the biggest thing about the Elavil for me is it completely messed my heart up. It changes the conductivity of heart muscle. And it activated a third node in my heart that was scary as heck. Very, very scary. So, you know, more, just remember, more is not necessarily better. For those of us who are sensitive, you might need a half of the lowest dose or a quarter of the lowest dose. Like I'm taking right now a quarter of a low pressor once or twice a day just to help me handle the stress and the rise in blood pressure I get when I'm dealing with my parents. I took a half a pill yesterday because they wanted me to do a half a pill 2 times a day. I had a terrible headache all day. Like my head was just pounding, and that's happened 3 times now. So I now know that a half a dose is too much for my redhead, but quarter of a dose is much more tolerable for me. Carol says, I also have IBS and it interferes with my IC. Well, the connection is the nerves. You don't have a bowel disease and you don't have a bladder disease. You have, I know how much I was paying for Sirius once a month. And I barely drove. I only turned it off, and now they can't stop calling me. They've offered me $4 a month to redo Sirius XM in my car, and I've still said no. That's like, give it to me for 99 cents, and I'll redo it. But I've given you way too much money. Carol says, thank you so much for your great input. I learned a lot watching today. I will not have so much salad, and we'll try other foods. Good. Melanie says, what about gabapentin? So gabapentin, you know, gabapentin is an interesting medication because it's been used off-label for pain for a long time. I mean, it's one of those medications where how do I say this? You know, the drug companies want to sell a lot of meds. They want to make money. And so they stretch sometimes to say this will help this or this will help that. So there is a very strong effort to start using gabapentin for pain. Well, what gabapentin does is it can help calm nerves down. And so if, for example, you have pudendal neuralgia, you have pain when you sit down that gets better when you stand up, or you have pins and needles, or you have areas of numbness, or you have PGAD, where we have a very clear sign that we have nerves that are very inflamed, then therapy for that is twofold. We want to do things that will release the muscle that's compressing the nerve, but we also need to now calm down this very irritated nerve. So how are we going to calm down this very irritated nerve? Well, if you have pins and needles on your skin, they're going to give you a topical, like topical lidocaine. But they might also suggest that you use gabapentin for a period of time to also address this neuroinflammation that's going on, right? Thoughts on Desmopressin? Let me take a look. Now I got to be honest here. I was stunned when I was diagnosed with high blood pressure. It really turned my world upside down. And it's normal 95% of the time now. I mean, as long as I walk and don't eat salt, I'm good. But I have moments when the stress builds. It built yesterday. And I just, you know, I can feel it rising. So Desperpressant is used to treat cranial diabetes insipidus. This is a condition that causes the body to lose too much fluid and become dehydrated. It is also used to control bedwetting and the frequent urination and increased thirst caused by certain types of brain injury. I don't have, obviously, since I had to look it up, it's not something that's come up. I don't think I've ever had anybody ask a question about Desmopressin, Deb. What's your experience with it? I mean, is it allowing you to hold more urine instead of peeing it out all the time? Denise says, what are my thoughts on D-Manus for bladder health? Well, it's pointless. Now, this is a great question. You know what? You just gave me an idea for a TikTok. Hold on. Okay. So D-Manus is a sugar like glucose, lactose, fructose, sucrose. It's sugars end with O-S-E. D-Manus is a sugar that the human body has no use for. When you eat it, it does nothing. The human body, it is impossible for the human body to use mannose. It is immediately excreted into your urine. So the only benefit that D-Manus offers is if you have E. coli floating in your urine, D-Manus will bind to the E. coli and you might pee it out. And the research studies give it modest success, not high success, just modest success. For women who have absolute recurring UTI, and God knows there are plenty of you, that's usually related to aging, doing D-Manus makes sense. I mean, we sell D-Manus in the IC Network store, but there's a better product called Prevent, P-R-V-N-T, which is a combination of D-Manus and proanthocyanidins, also known as PAC. And it's that magic combination which research has found to be the most successful. The brand that most people know of is called Ellura, E-L-L-U-R-A, is probably the most popular UTI preventative on the market, but Allura is very expensive. And so one of the top IC researchers asked Natural Approach Nutrition if they would create a more affordable mannose PAC product, and they did. It's called Prevent, PRVNT, and it is their best-selling product by far. Prevent outsells everything else. It's absolutely stunning how successful it is. And so go on over to the ICN shop, go to IC Network and just click on the store, and you can see it right on the front page of the IC Network shop. Mary says Gemtesa is new and in the same family as Myrbetraq. You know, here, hold on a sec. Let me just look at this real quick. Vibegron. Yeah, because Myrbetrix is a Mirabegron, so this is a Vibegron, the beta-3 agonist. Not that you need to know that. Rhonda says, I have to take the Valium. I suffer with bad urgency nonstop. As soon as I get just a little nervous, I have to go. You have to go. You're hoping that physical therapy will help. Well, okay, so let's think about this for a moment, Rhonda. So what does Valium do? Valium is a muscle relaxant. It's skeletal muscle relaxant. So what would be interesting would be maybe to try it in the form of a vaginal Valium suppository. When you're taking Valium, you know, for those of us who are just a wee bit on the older side, Valium was a very popular medication for women in the 60s to take just to cope with the stresses of the day. Just kind of a sedative. It was kind of like the Xanax of the 60s. And unfortunately, Valium has the potential of being a little bit addictive. And so using it as a topical rather than as an oral, so a topical cream slash insert, vaginal insert, delivers the medication exactly where you need it, which is to the pelvic floor, without being sent to your brain and through the rest of your body to any great degree. So, and Rhonda, the other thing I would just say to you is if you feel better when you use Valium or Flexeril, which is what I use. I take a quarter of a Flexeril almost every night for my muscle tension. Flexeril has the same thing. It can have a little bit of a sedative effect. Maybe you should talk to your doctor about Baclofen, Baclofen. Baclofen is a non-sedating muscle relaxant. So you can take Baclofen during the day, you can drive, you're fine. So and maybe instead of the Valium, you could ask for the Baclofen. You might be able to use it a little bit more consistently. But I guess more importantly, I'm really glad that you're going to physical therapy. I think that the physical therapy, hands-on work on your muscles is always the best. Now, if we can get these muscles to calm down and get them out of spasm, you're good. And then you won't need anything, right? Linda says, sometimes I take hydroxyzine 10 milligrams at night for my IC. Originally, I was prescribed 25, but I felt like a zombie the next day. Can this cause dementia? So hydroxyzine is an anticholinergic, but it is not as bad as the low-dose antidepressants. I mean, I took hydroxyzine every night for 25 years. No, I'm sorry, for 10 years. It was a 25 milligram capsule. They had me cut the capsule in half. I did half a capsule, 12 milligrams. I didn't do it every night, but I did it. I used it consistently. Hydroxyzine is an antihistamine. It's a low dose antihistamine that just kind of calms the mast cell activity in the bladder, which can drive some of the irritation you might be feeling. The nice thing about the hydroxyzine is it has a very nice beneficial side effect in that it also calms anxiety. It has a very nice anti-anxiety effect. And that's really why I took it. And it has a higher success rate in people with a history of allergies. I can remember when we did our IC, I learned about it at the first IC conference I did. I was eating dinner with Dr. Lowell Parsons. We had a little group of people eating dinner before the event. And he was sitting next to me and he goes, "Do you have allergies?" And I went, "Yeah." He goes, "You should look at this hydroxyzine. We're not really sure why it helps, but it's helping a lot of people." And I'm like, I was willing to do anything back then. I talked to my doctor. He's like, "Sure, you want to try it? Not a problem at all." What I found with the hydroxyzine is that it's a little bit harder to wake up in the morning. It's like there's an extra layer of sleep that you have to break through to get up. So it's not good to take it right before bed because there's like a 10 or 12 hour half-life for the medication. It's better to take it at dinner time because then you've got a few extra hours for it to work out of your system so that by the time you're waking up the next morning, it's easier to wake up. But there's just this layer of something you got to get through. Once I was through that layer, I was fine and there was no sedation for the rest of the day. But it really helped me sleep. In fact, it would probably be good right now. I'm only getting like 6 hours of sleep right now. Maybe 7. I mean, most nights it's 6 hours of sleep and then I'll do a 9 hour every 4th day or so. Interesting. I have it. You're welcome, Rhonda. Susan, so cool. Susan says, my doctor had me make my own vaginal inserts with baclofen mixed with coconut oil. Freeze in a small ice tray. Has helped those nerves, and it's much cheaper making it myself. Are you, I guess, now, Susan, this is going to sound weird, but I'm thinking about sterility here. And I just had to buy a refrigerator yesterday, as a matter of fact. In my refrigerator, we don't have an automatic ice maker because I don't have water going to where the refrigerator is. So we have the old trays, and it was just gross. I just didn't like them. And so, because they connect, I mean, you can always taste ice made out of a tray. It just tastes stale. So I'm wondering how do you reinforce sterility? Do you maybe coat it with plastic wrap while it's freezing so nothing that goes in and out can go over the top of it? Love to know your method. I think that that's absolutely great that you're doing that. I love it. Thank you, Denise. Deb says, I used to get up every 60 to 90 minutes at night using Desmopressin for 1 week so far. I'm able to sleep for 3 to 4 hours. It affects the pituitary gland and your body doesn't produce urine as quickly while asleep. I make up for it in the morning, which is okay. I will have to get your sodium levels checked again in 3 months. So Deb, this is what I would, number one, listen, it's working for you. That's great. But you're chasing a symptom. You're not addressing underlying causality. So if you're getting up every 60 to 90 minutes at night, then that tells me that your bladder wall was compromised and or your nerves were compromised. So the reason why the Desmopressin is working is it's overriding whatever the underlying problem is, but it's not fixing it. It's not fixing it. So all I would say to you is you have to think about causality too. So is the reason why is your bladder so vulnerable? Is it because of estrogen atrophy? I can't tell based on your picture how old you are, but you have to remember that as we get older, we start to lose this coating. We call this the gag layer, the glycosaminoglycan layer, or the mucosal barrier. Unfortunately, I mean, think about the bladder. It's the only organ in the human body designed to hold toxic waste because urine is body waste. Urine contains ammonia and urea and all sorts of irritant. So how can the bladder hold ammonia for hours at a time and not get damaged? Well, this is an evolutionary marvel. It turns out your bladder is like your mouth. It's a hollow organ covered with a really thick, robust coating of mucus. This blue, it's not blue, this is just for educational purposes, but this mighty mucus plays a critical role in bladder health because it's a barrier. It prevents whatever's in your urine from reaching these more fragile cells and the nerves underneath them. Unfortunately, it is estrogen dependent. So when you're young and you have lots and lots of estrogen, you have lots and lots of mucus and you can get away with stuff. Honey, but once you're over the age of 50 or you've had a hysterectomy or you're on Lupron or even some birth control pills, guess what? You don't have the estrogen, which means, whoops, you don't have the mucus, which means that your bladder's ability to defend itself is now greatly compromised. There's no disease happening. That's not a disease. That is what we call the genitourinary syndrome of menopause. So you can see now that when that blue layer is missing, whatever's in your urine gets there. And so I would just challenge you to think about causality, because for the estrogen atrophy patient, the most important ingredient in therapy is estrogen. That when you give that skin estrogen, it immediately produces mucus. You can watch it, the video, you can watch it on an electron microscope. These dry, shriveled cells immediately start to plump up and they start to produce mucus. Topical estrogen is stunningly safe and stunningly effective for genitourinary syndrome of menopause. I know because I use it. And for me, it started when I was 52 and I felt like there was a drop of urine in my urethra that would not come out. And, you know, listen, my IC skills are really good. My self-help skills are really good. I have polished them for 30 years. Nothing I did fix this urethral pain I was having. I was baffled and it was annoying as hell. So I threw myself on the mercy of my urologist and said, what is wrong with my urethra? Please help me. I said, it feels like there's a drop of urine stuck in my urethra that will not come out. So he did a sonogram. He goes, well, you're emptying your bladder. That's not it. Put me in the stirrups, took one look, and I tell this story all the time. I'm laying there, you know, in the stirrups. He's down there looking. And he goes, Jill. I'm like, what? What did I do? And he goes, didn't you use the estrogen cream I prescribed for you last year? And I said, no, laying on my back, looking at him through my knees. No. And he goes, why? And I said, because in my brain, I'm 25 years old and I can't possibly have an age-related issue, which is true. And I'm now 10 years older and I still feel 25. I'm a little bit more receptive now to the concept of age-related issues today. But anyway, he laughed and he goes, I saw this happening a year ago. That's why I gave you the estrogen cream. And then he explained that the urethra is kind of the canary in the coal mine. It's the first part of the urinary tract to start reacting when you lose estrogen. And how does it feel? It burns and it feels like there's a drop of urine stuck in there. Now, fair warning, if you're dry and you start to use estrogen, it's going to burn. It's going to burn because your skin is dry. It's not hurting you. Estrogen cream is not hurting you. It's going to feel hot as hell. Like that. For me, the first time I used topical estrogen, it burned for about a half an hour. But every subsequent time I used it, it got better and better and better, because every time I used it, the skin got healthier and healthier and healthier because it was immediately using the estrogen. So a lot of women make a terrible mistake. They use estrogen once, it burns like the dickens. They go, I'm not using that. You can't do that. Because if you wait, the next time you try to do it 5 years later, the burning is going to be that much worse. So you have to ride through that initial discomfort. And now when I use the estrogen, it's like a little warm puff of air. It's like a poof, and then it's gone. If I don't use my estrogen for 2 weeks, the burning starts to come back. So I always have a clue as to how my urethra is doing. I mean, how my hormones levels are based upon how my urethra is feeling. Christine says, do you have mucus when you wipe with your IBS? You know, I did, hon. I had moments where, and those were the most painful moments. It's when your stool mine was just covered with like white slippery webbings of mucus, and I associated that the most with dairy products. When I stopped the dairy products, the mucus went away. That was one of the big mysteries for me, was understanding where this mucus was coming from. And for me, it was from dairy. I eat cheese, but I don't drink milk. I will occasionally do a low-fat ice cream, but I never drink milk. I don't cook with milk. I use Mocha Mix for all of my dairy replacement, and it works like a charm. I was going to say, I wonder if this book talked about that. I mean, I got that somewhere. Yeah, here we go. Milk allergy. Hold on. 66. Hold on. Let's see. The milk protein allergens are casein, alpha-lactalbumin. Okay. I don't remember where I got that, but anyway. Susan says, you wrap it in plastic wrap and only a few at a time. Okay, perfect. Susan, I love that. I love that. That is so cool. Carol said, I took this medication she's talking about for years, and after a while, it did not help me. I got off of it. Okay. The Desmopressin. Deb says, I'm 62 years old. Hello, birth sister. I'm 62 also. You've been using estradiol for a year. I have had my Hunner's lesions cauterized twice. I also use Mirbitrate. So Deb, so understand that because you have Hunner's lesions, you are in a very distinct group that I'm not in. In our subtyping system, we have 5 core variants: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and chronic overlapping pain conditions. Hunner's lesions are a unique beast. And there's been a lot of mystery as to why Hunner's lesions happen. Theory number 1 is that it's infection. And it was researchers in Europe who found a very specific virus in the urine of patients with Hunner's lesions called the Polyoma Virus. This was 5-6 years ago, maybe 7 years ago. We have multiple studies now, including a study from our own National Institutes of Health, which found virus in about 5% of IC patients, usually the Hunner's lesion patient. So what is this virus? The Polyoma virus is a virus that we all have. It's part of what we call the human biome or virome. It is not a sexually transmitted disease. Nobody is saying that this is a sexually transmitted disease. It is a virus that gets turned on in people who are immune compromised. And so polyoma virus has long been associated with what we call hemorrhagic cystitis. So it gets turned on in patients who are immune compromised. So if it's somebody who's had a kidney transplant and they're on immune suppression drugs, that's when the virus kicks off in the bladder. Or if somebody has HIV, a lot of those early HIV patients have ended up with hemorrhagic cystitis from this virus turning on. So it might be interesting to have a viral test. It's a blood test just to see if you have any active infection, because if you do, then they might suggest that you use an antiviral medicine. But the other case, it was even more interesting. Again, our second theory about Hunner's lesions is that they're being driven by a nerve that is massively inflamed. And of course, viruses live on nerves, so that kind of supports that. A neuroinflammation is devastating because a nerve that's inflamed releases something called substance P. And substance P is a biomarker of inflammation, and it's damaging. Substance P damages tissue. So somebody with a nerve injury, the area often turns red and often becomes injured because of the production of substance P. So we had a very interesting case study released last summer, 2 summers ago, of a woman who had severe Hunner's lesions and she had a severe prolapse. And then when they went in surgically to repair, they had to repair the prolapse because she couldn't pee. And that was a surgical repair. So when they went in to do that, they made a remarkable discovery that her uterus was flipped backwards. The back of her uterus was facing front, and the front of her uterus was facing back. And that is because one of the ligaments that normally holds the uterus in place had broken. So her uterus was swinging on one ligament and going all over the place. This is called, the name of the diagnosis is Posterior Fornic syndrome. It's a strangulation injury. So what that means is that the tissue is now twisting. Strangulations are devastating. Men can have strangulation injuries in their testicles. And it's always a surgical emergency because when you have a strangulation, blood flow is cut off and nerves are being damaged. So anyway, her uterus was flipping. And it might have been going in a full circle. I don't know, possible. So when they repaired it and got her uterus in the proper position, her Hunner's lesions healed completely. Completely. So that supports a neuroinflammatory theory. Posterior, and it'll come on. Rhonda said estrogen burned for her too when she used it, but nothing like the fire I had. All right, I'm no longer, nope, it's still a little dehydrated. So today I am channeling my anti-mister. I am the anti-mister of my generation. And I am wearing her ring. Can you see that? My mom. This is the only diamond I have. I'm not a ring girl. I don't normally wear things. Auntie Mister was single her whole life. She didn't want to be. She fell in love with a man deeply. But he was, and this was back in the 40s, in the 50s. He was in a very unhappy relationship. And even though he and his wife were separated, he would not divorce her because of his church. And she was desperately in love with him for years and years and years and years. And in the end, she could not be with him. And so she became kind of the family, guardian angel. She's like a guardian angel, Auntie Mister. And so I always feel her. I always feel certain. So I was very curious because I wasn't feeling good when I woke up. So I got to tell you what happened yesterday. And again, like I'm in a more anxious mode right now, right? So I'm not normally, I'm struggling a little bit with anxiety now that I wasn't doing 3 months ago. And again, it was the whole high blood pressure thing. So and my parents getting worse, and just all that stress. So yesterday I had to go get new tires for my car because they were worn down. My front tires were almost bald, and I saw that. And our refrigerator broke, so I had to go get a refrigerator. So I get ready, do everything I need to do. I'm like having a really good day, and I go get my tires fixed. $1,200. Okay, fine. I drive away, and the little warning light comes on. They didn't balance the tire pressure. So I had one tire at 40 and one tire at 30. And I can't stand warning lights in my car. I can't. I'm one of those people. It makes me crazy. So I got 2 miles away, turned around, came back. Guys, could y'all please check the pressure in the tires, because one is 10 off of the other. This is not right. So they're like very begrudging. We're so sorry. They go in, they fix the one tire. Thank you. I drive away. Now it's just 5 degrees apart. I got one tire at 36. I got 2 tires at 36, one at 33, one at 30. This annoys me. Makes me crazy to see warnings like that. It's like, guys, balance the freaking tires. So anyway, I'm not going to go back. I go do what I need to do. I'm doing all the rationalization. I'm perfectly capable of going and putting air in my tires. I'm perfectly capable of doing that, but I didn't do that. Instead, I went home and I worried about it. Ruminating, right? It's like, okay, I can go back on Monday. They can do it on Monday. I can go do this. I can go do this. And I just stewed. I stewed in my warning light all evening, and I could feel my stress rising, right? And then I think keeps me up a little bit at night. I just want things stable. And I'm not normally like this. I'm just vulnerable right now. Wake up this morning. First thing I think about, freaking tires. And it's like, all right, I am not going to lose another day to this. I am perfectly capable of going to the gas station and measuring my tires. So I get up, change clothes, drive to the gas station. It cost me 50 cents. I've got my thing. I don't know why I was even worrying about it. Why was I even worrying about it? Now they're all 36 and it's fine. I drive away going, good job. You fixed it. You don't need to worry about that anymore. What annoys me is why I was worrying about it in the first place. Why was I worrying about it? It's just tire. It's just air in the tires. There's no danger to it. But that's what happens with elevated levels of anxiety. Is what happens is the salience network in your brain changes and it starts to interpret non-threatening things as threats. And I'm interviewing Dr. Jason Koch at USC, who is doing research on this with IC patients, where they're really trying to change the way the nervous system is functioning for those of us who have chronic overlapping pain conditions. And we were when I was talking with them, we were both talking about how we have periods where our anxiety intensifies, and we go through a period of time, the anxiety intensifying, and then it calms down again. But when it does intensify, things that are not threats, your brain starts to interpret as a threat. And so anyway, I was very annoyed last night and annoyed this morning, and I went and fixed it. And I came home and I stopped and got some coffee cake from my parents and talked to somebody for a while. And then I came home. It was 9 o'clock or 9:30. And I thought, all right, time to go for a walk. And I could still feel the 24 hours of stress. Did a long walk, doing my deep breathing, just trying to calm everything down. On the way back, I passed this sweet old man who's walking with 2 canes. So we did, said, good morning, wonderful day. And back on the other side, I ran into him again. So this time I decided to, talk with him. So he was walking, I was walking. So I walked up beside him and I said, well, so I'm walking to reduce my blood pressure and stress. Why are you walking this morning? And he goes, well, I'm recovering from a stem cell implant. And I'm like, wow, are you okay? He goes, well, my cancer came back. I was like, oh man, I am so sorry. How are you feeling? He goes, I'm feeling pretty good. I'm feeling pretty good. And I was like, oh, I'm so, and it was recurring of Hodgkin's lymphoma. And that's what I needed, because that gave me context. Here I am worrying about freaking air in my tires. And this guy is worrying about having a PET scan in a week to determine if the cancer is spread in his body. And it was just like this light bulb again, which we all need to get you out of your thoughts and your little world, to give, that world that you get stuck in, for context. And I looked at him, and a sweet, sweet man. Oh my goodness. I actually never met him before. And we just had this delightful little conversation. And I walked back to my house going, there you go, Jill. There you go. You have nothing to be worried about compared to him. You fixed it. It's done. It's over. And look at what you did. You made him feel better. He made you feel better. It's about supporting each other. And so that turned my morning around, I mean, it's just like, okay. Thank you. Thank you, God, for giving me a reminder yet again. We get so caught up in our own little is not demeaning. We get stuck in our own lives that we start amplifying things, that it's bigger than it is. And it takes just one sweet moment that gives context. And I'm grateful that I always think that when something happens to me, it's the only way I can validate my life, really, to be quite honest, is for all the stress and trauma that I've gone through. And many of you know I've talked about that. Involved very, very bad things that happened when I was younger. When things like that happen, it's just like, okay, what are you supposed to learn from this? How are we going to use this to make your work better? And I just really, for me now, I really want to take a step back and just work on breaking out of fight or flight. I realize I have been in fight or flight my entire life since 4th grade. I have moments when it's suppressed and I'm really good. And then I have moments when it comes back. And we know why that happened. It was about trauma that happened when I was younger, and a murder that happened when I was younger. My neighbor was raped and murdered, and the guy who did it, he tried to come after me. So believe me, I have trauma. I realize that has affected my entire life, that my actions have been limited by fight or flight my entire life. I would love to be able to get on a plane and go somewhere and just enjoy it. I never enjoy it. I'm in fight or flight. I just want to come home and be safe. That's the way the primitive part of my brain behaves. I want to be home and safe. And I am home and safe, but that's limited my life so much. I want to get out and do more. I do a lot already, and I may have spoken at 2 big conferences this year virtually, but I just want to learn how to really retrain my brain completely out of that fight or flight, right? Rhonda says, wow, that's me. I'm home and safe. I can go out, but I won't. I mean, I go out all the time, but I don't enjoy it. That's the thing is I don't enjoy it as much as other people enjoy it. I don't enjoy going out to restaurants and eating other food because of the food sensitivity. I don't, it's work. It becomes work. Tamara says, I'm just like you. Yeah. And it's just priority. Mary says priorities. We all do this. And Rhonda says, yes, thank you, God. We focus on our own problems when we don't mean to. Yeah. Mary says, I think we're all overly stressed. Sometimes we just have to say, just do it. Bingo. Anxiety is the root of all this type of behavior. It is. And I didn't understand how the brain changed. And that's what Jason is teaching me. I mean, that's what the International Pelvic Pain Society was working on 3 years ago with at that wonderful conference that I was at. And the great thing about it is it's taken the shame away completely. It's like, you know what? None of this was ever my fault, ever, ever, ever. That this is what happens with trauma. This is what happens. And Mary says it's affected your central. Exactly. It has. It's affected the most primitive part of your brain, which is the sympathetic nervous system. And what the research shows for those of us with chronic overlapping pain conditions is that our brains are literally stuck in fight or flight. You know, the primitive part of your brain has one job, and that is to save your life. And all it's doing is paying attention to your sensory information. What do you see? Is it a fire or is it a rose? What do you hear? Is it screaming or is it your favorite music? What do you smell? Is it smoke or is it a rose? So the sympathetic nervous system, all it's doing is monitoring your sensory information. And if it detects a threat, it takes over because its job is to save your life. So if you open your front door and you see a saber-tooth tiger across the street, the sympathetic nervous system pays attention to that, takes control of your brain, turns the amygdala on, raises your heart rate, raises your blood pressure, tightens your muscle. It's preparing you to fight or flee for your life. That is what the sympathetic nervous system does. Okay, but you call the authorities. The authorities come, they trank it. It's gone. It's been gone for an hour. It's not there. Normally, at that point in time, the parasympathetic nervous system takes over and it calms everything down. It lowers your heart rate. It lowers your blood pressure. It relaxes your muscles. But what the research is showing is that's not happening for those of us with chronic overlapping pain conditions. That our brain is literally stuck in fight or flight. And it's not mental illness. Nobody is saying this is mental illness. This is injury. It is injury to the central nervous system. 14 days of pain will do this. 21 days of bullying will do this. And so it's fascinating now to kind of put all those pieces together. Why do so many IC patients struggle with anxiety? Now we know why, because you're in fight or flight. I'm in fight or flight. And so what Jason Koch is doing at USC, and we're going to be sending out the clinical trial announcement, is they're actually doing a very specific type of nerve stimulation. And it's working. The data is really promising. So I'm going to do a big interview with him this week. I've got to come up with my questions. And then on the IC Network website, I'm going to build a whole new mind-body medicine. I'm rebuilding huge portions of the IC Network. When you go to the IC Network, there's going to be literally, before you even get to the front page, it's going to be are you in a flare? Click here. Are you newly diagnosed? Click here. Are you a veteran IC patient not responding to therapy? Click here. And there's going to be video after video after video, walking every patient through those scenarios. And I want to have a whole section on mind-body medicine because I want to take the the shame of thinking that you have a mental illness out of it. Mary says, fabulous conversation. All this leads to paranoia. I don't know about that, Mary. I mean, I don't feel paranoid. I honestly, I don't feel paranoid. I don't. I am guarding. My brain is guarding. And so when I think about my behavior, it's the behavior of somebody trying to protect you. And so, and it's hard to turn off. Please, Jill, you have broke through so many things doctors couldn't do. I'm having faith in you that you will have info on how you want to let go of the guarding. Yeah, I mean, it's just a defense mechanism. It's just a defense mechanism. So what I have been saying, and when I was in the shower this morning, because I had to wash my hair, I did tapping, and it actually really helped. So tapping is, they call it emotional freedom tapping, and this is used for, here, hold on, I got to fix this a little bit. Tapping is used to turn off the sympathetic nervous system and turn on the parasympathetic nervous system. And, I mean, the brain is like a thunderstorm on the inside. Different areas of your brain light up. It's really beautiful. I mean, if you've ever flown through a thunderstorm, that's the way your brain is when you're thinking and doing stuff. It's just different areas light up. And so one of our strategies that we can use for chronic pain is, if we keep portions of the brain busy, it cannot then be consumed by the pain and become involved in the pain process. And that's why they say it's really good to do puzzles, things where you're, keeping parts of your brain busy, just with busy work, whether it's crocheting, whether it's doing sudokus, wordles, whatever. Just keep, or for me, I used to make a lot of stuffed animals, love making and painting rabbits and things like that. Okay. So anyway, we want to keep the brain busy during these periods of high stress. And so with tapping, what we're doing is we're engaging the area of the brain that focuses on touch. Touch is one of the 5 senses, right? Seeing, hearing, smelling, touching, etc., tasting. So with tapping, what we're going to do is we're going to touch different parts of our body just to get the attention of your brain. And so with the tapping, where did I start? I think I started right here. So I did it 10 times. And then what I said to myself is, you are strong, you are capable. 2, 3, 4, 5, 6, 7, 8, 9, 10. And then I did my affirmation. And then I went here. 2, 3, 4, 5, 6, 7, 8, 9, 10. Now my brain has no idea why I'm doing that, but there's no threat to it. So it's okay. And we're always following it through with an affirmation. I am strong. I am capable. Then we go to here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Then we I did here, which is below about an inch below your collarbone and in. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then underneath both armpits, right around your bra line. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And what's interesting is I felt immediately better. I mean, I really got myself worked up over freaking car tire pressure. Live and learn. And so getting back to what I was saying at the beginning of this meeting, ask action satisfaction. Don't sit at home and stew and worry. Don't do that. Take action. So I woke up this morning. I could tell I was going to think about it all day, and it was going to annoy the hell out of me. It's like, I'm done. I'm freaking done. I put my clothes on, put my shoes on, grabbed the tire gauge, went to the gas station, and I fixed it. And I fixed it in less than 2 minutes. And yet I worried about it for 20 hours. That's a brain that is not that's a brain that's stuck in that fight or flight again, and it's interpreting something non-threatening as threatening. No shame, no blame. I get it. Mary says, I should say for some people, tapping is great. I do it every day. I'd love to hear your technique. And painting the front porch. You know, I'm telling you, one of the ways that I'm gonna cope with losing my parents, because that is gonna happen sooner rather than later, is I love painting. I'm gonna paint this whole house. I'm gonna paint the bricks. I'm gonna paint everything. Rhonda says, I hate when I'm finally am done and it's too late to do anything. You know, hey man, I did a jigsaw puzzle last night till 2:30 in the morning, and I was watching either House of Dragons. No, I was watching the Hobbit one on Amazon Prime. It was really good. All right, guys. Well, listen, I think we've kind of come to our natural end for the day. Great meeting. Anybody have any questions? I'm here. I'm feeling good. I'm happy to take any other questions. So let me do a last call for questions. I will stay as long as you want me to stay. If you're done, I'm done. But because I don't need to walk today, because I've already done my walk. So normally after these meetings, I'd go walk a couple miles, but. Thank you on the ring, Auntie Muster. I never met her. I feel good about her, though. Last call for questions. Last call for questions. I think that the man she fell in love with gave her this ring. It feels magical. Kind of feels magical to me. Thank you, Melanie. You're welcome. Mary says, add a phrase as you